Apparently my voice for some people is bouncing, whatever that means, but I will keep it quick. So we're very delighted at Cirtex to host that webinar and to host that faculty. I'm going to soon hand over to Professor Ono, who will introduce our great faculty. Just want to give you a few details. So it's supposed to be interactive, so please feel free to unmute yourself, to type some message and some question throughout the presentation. We would appreciate that. The last thing I wanted to mention is that meeting is recorded because we would like to make it on demand following the meeting. So some people have registered and unfortunately won't be able to attend, but there will be an on-demand video following the meeting. So on that note, Professor Ono, I'm going to hand it over and I'm going to keep quiet from now.
Thank you very much. Thank you, Antoine. Good morning, good afternoon, and good evening, everyone. Thank you very much for joining us for this great webinar. Today, we're talking about CERT, especially in the light of the recent update of the doorway study. My name is Maxime Renaud. I'm an interventional radiologist working in Paris, France, and I will be hosting this webinar for you today. So today, we have two great speakers who will share their point of view and data about that. First, we will welcome Prof. Chinu Kapadat, who is a nuclear physicist working in the MD Anderson Cancer Center in Texas, USA, and is the co-PI of the doorway study, will be the first speaker. And then we will be happy to welcome Prof. Kim, who is an interventional radiologist working in the Seoul National University Hospital in South Korea. And he has one of the largest Y90 practice worldwide outside of the US. The idea is to listen to the lectures, and then, of course, you can ask questions. And after the two lectures, we will have some time for question interactions. So feel free to challenge the faculty, ask questions. And without further ado, I would like to give you the floor, Professor Kapadat.
Thank you very much for that introduction, Dr. Renaud. And as you said, good morning, good afternoon, and good evening to everybody. It's really a pleasure to be here today. Let me share my screen. Is that coming through okay now?
Perfect, we can see it.
Okay, excellent. And I really want to start off by thanking Antoine and Cirtex for inviting me to actually present this webinar here. So without much further ado, let me present to you the top-line results of Doorway. So the lecture is entitled Doorway, Selective Internal Radiation Therapy using Cirsphere's Y90 resin microsphere as a first-line treatment for unresectable hepatocellular carcinoma. So my name is Chinu Kapadat, and really I'm showing you my co-PI on the study is Dr. Armin Mavash, who is an interventional radiologist, and I'm a medical physicist. And I'm presenting this on behalf of the full Doorway collaboration, okay? And I will present towards the end who the participants in the sites were, but I want to just list our disclosures for transparency. So Doorway is really the first pivotal, prospective, multi-center, open-label, single-arm study using resin microspheres and partition dosimetry for the treatment of unresectable HCC. Okay, this was designed primarily to evaluate Y90 resin radioembolization as the first-line treatment for unresectable and unablatable HCC, right? So it kind of follows in the footsteps of it, okay? But the design is slightly different. So what are the two co-primary endpoints? There are two co-primary endpoints. This actually was a study that we have gone to the FDA, and FDA gave us, reviewed it for an indication label, right? So they gave us two co-primary endpoints to work on. One was the objective response rate using modified RECIST criteria. And this was the best response through 9 months. We evaluated from treatment up to 9 months, and the goal was to get an objective response rate greater than 40%, okay? The second co-primary endpoint was the duration of response. And duration of response, it is the interval from the first time of response, which is either a CR or a partial response, CR meaning complete response, until disease progression, right? And again, we are using the modified RECIST criteria. So we are also, remember, the last imaging response assessment was at 12 months after treatment. So really the maximum duration response we could expect from a study is 1 year, because that's what we followed up on, okay? And the goal again here was the FDA expected us to have in 60% of the patients, at least a response that is durable greater than 6 months. Okay, so these are the two core primary endpoints of the study. There were several secondary endpoints as well. One was to look at toxicities. Obviously, it's very important in the first-line setting. We also want to look at the quality of life. And again, we want to see what is the incidence of a liver resection, liver transplant, for these patients. And I'm showing you here a table that basically that shows up the assessments, that shows tumor evaluation of the various months, quality of life questionnaire, adverse events. And you'll notice that at 24 months, there's going to be a separate call just to assess safety, long-term safety. So who are the patients that were treated in Doorway? So this was treatment-naive patients, right? This is first-line treatment. But you could actually have a prior curative treatment, which is either resection or ablation for less than 3 centimeter tumor. And this has to be a new lesion after that, right? So it's not like you would have resection or a poor ablation and they progressed. No, I mean, those were treated. There's new lesion, those are okay. We spanned across the BCLC stage, A through C. Maximal single tumor size was about 8 centimeters, and the sum of tumors was 12. Clearly, these are not suitable for resection or ablation per the site PI at screening. ChalPUA, ALB 1 or 2 with an ECOG status of 0 or 1. Okay? So those are the general eligibility criteria. Then the exclusion ones, we said, okay, if you had any prior anti-cancer therapy, such as immunotherapy, radiation therapy, other investigational drugs, then you were excluded from the study. If you had a PBT or extrahepatic disease, we also excluded you from the study. There were several salient features I want to highlight before we get into the results. The first one is we actually utilized partition dosimetry for treatment planning. Okay, so we used MA spec CT, and we used that for treatment planning. And the dose to the tumor based on partition was bracketed between 150 to 400 gray. Okay. We were allowed to do radiation segmentectomy up to 1 or 2 segments that were treated, where we used single compartment dosimetry, not partition dosimetry. And in this case, we took the partition dosimetry formalism and collapsed the TNR to 1, basically, which comes down to single compartment dosimetry. And then we said the dose to perfused volume would be 150 to 400, right? So we really used the partition model dosimetry paradigm. And in all the treatments, we used 3-day pre-cal spheres, right? So the specific activity of spheres were the same. So we were trying to have a very consistent model for treatment so we can actually glean the science out of it. We also defined an actionable endpoint, right? So what we said is we have to do the treatment. We need to do imaging of this, and we need to confirm that the radiation and the treatment go where we planned it to go. If there were some issues, in the protocol, we said within 4 weeks, we can retreat the patient, okay? And this is very much in line with even your treatment. If something is wrong, you go back and retreat again. But the whole idea is to do it very quickly. And that was done. The other aspect was we wanted to do several things to reduce robustness, enhance robustness and reduce bias. And one was we had a centralized review. So the national PIs, Dr. Mavash, myself, and the site PI sat together and looked at the treatment plan just to make sure that all aspects of the study were being reviewed and addressed. Also, the response assessments were done by an independent core lab of radiologists. This is the American College of Radiology. So they had no knowledge of a completely independent. And there was also an independent data safety monitoring board. Okay? And like I mentioned before, we assess response and safety up to 1 year in 2-month intervals. And there's an additional safety follow-up at 2 years. So what is the timeline of the study? So the protocol actually started designing early 20s, and we had meetings with the FDA sort of late 2020s, and the protocol was finalized right around Christmas time, right around then someplace. And we opened the study in March 2021. So you can see all of this happened sort of during COVID era. First patient was treated March 28, 2021. Last patient was treated on August 6th, right? So we had, 2.5, 3 years to basically get all the patients done. Last imaging response was completed on August 6th. That's because 1 year follow-up is done. And the last safety is going to be completed to be coming in a couple of months, which will be August 6, 2026. So this is just a safety. But all the imaging response is done, and I'm going to present that data today. I want to point out that last year at CERSI, I presented the interim cutoff data as well. And this year, SIR, Dr. Mavash presented the top-line results of the Doorway results. I'm going to present some of that stuff here as well. So here's the consort diagram for the study. So this was a 100 patients study that we needed to treat. We had to consent 160 patients for this, and the reasons for exclusion is shown here. But I want to point out that ERC, that is the eligibility review criteria, this is where the treatment planning got done, but the site PI and the national PI. We look at that and we do decide that, oh, some of these patients don't really fit in there. So 100 patients got treated. Out of that, 71 completed full 1-year follow-up. There were several patients that withdrew due to death unrelated to treatment, liver transplantation, they withdrew consent, they were lost to follow-up. So in the end, we had 71 patients that completed all of the 12-month assessment. And then we are in the throes of doing the complete 2-year follow-up. This number still needs to be updated. This is an older slide here, but this is coming up. And by August 6th, we should have this completed as well. Even as we go from 71, there has been additional deaths and transplantation that's going on. So, as a typical study, as we go further in time, some of the numbers go down. So, but the point is we've treated 100 patients, we completed 71 patients have had full 1-year response assessments, and I'm going to present those results today. So here's the baseline characteristics of the patients here. Median age was 69. We had about 79% was ECOG 0. Everybody obviously Child-Pugh A with about 80% A5. You can see here's the distribution of the BCLC stage. And we have a BCLC-C here that is 21%, but these are primarily due to their ECOG status and not due to necessarily their disease status, okay? So yeah, the ECOG status here, they're primarily because they're ECOG 1. So, and they're 92% of the patients have confirmed pre-existing disease, right? This is hepatocellular carcinoma. So those are the patients. What are the tumors that we targeted? So in single tumors, that's shown right here, we can see that the median size was 2.8 centimeters with a range of 1 to 8. And 68% were less than 3 centimeters, 56% were less than 3 centimeters, 34% were between 3 and 5, and 11% were greater than 5 centimeters in size. Okay. We also had 24 patients that had multifocal disease. Okay. And so in these cases, the sum of the tumors, you could see 41% was less than 3, 33% between 3 and 5, and about 26% that was greater than 5 centimeters. And in this size, the median size of the tumors was 3.4 with the range from 1 to about 10 centimeters. How did we approach treatment for these patients? We did segmentectomy in 76% of the cases and pure partition dosimetry in 24% of the cases. Okay. In terms of treatment delivery, 97% of all the cases had complete delivery of all the planned activity, right? So there was no issues with incomplete delivery here. We had 3 cases that was incomplete delivery. In 2 such cases, there was stasis. And the 2 cases that had stasis, the tumor absorbed dose was calculated to be 369 and 194 gray. And kind of following up these patients, both of them achieved complete response and duration response greater than 6 months. So these stasis didn't really cause any issues out there. And there was another case that had an incomplete treatment due to reflux of the contrast. Okay, so there basically the delivery was stopped. The patient actually achieved complete response as well and did not have any serious adverse events. So those are the 3 cases. Then I mentioned we actually do post-treatment imaging to assess delivery of the radiation to the target sites. We found there were 3 instances where there was suboptimal delivery radiation. In one case, we noted an additional segment got treated. In one case, there was a movement during the procedure, and there was and the one part of the and the tumor got underdosed. And in the third case, there were 2 segments being treated, and one of the segments got underdosed. Okay. And out of these 3, 2 of them were retreated. So, basically based on, we had a discussion with the site PI, and for 2 of them, we said, hey, let's quickly go within and retreat them. And one of them decided it's okay. I don't recall which is which case here. So in terms of endpoints, I'm delighted to say that both co-primary endpoints were achieved. So we really had 96 tumors out here. And out of these, 99 had objective response through 9 months. So there was a 99% objective response rate that we report on, with 90% CRs and 9% PRs, right? So it's very important to recognize that the one patient, or 95, why is that the patient didn't have a objective response rate? Because their imaging was non-evaluable by the ACR. So it wasn't that we didn't do the treat, there was an issue. They just couldn't, the imaging that they acquired from the site was something that the ACR said, I really can't really tell if this patient responded or not. So what's really important to understand is that we got really 100% tumor control, right? So within doorway, all the tumors that we could image, we could get a response. And there was no local progression, right? So that's very good to hear. We got very good control of disease. Now, in terms of duration of response, if you go to duration response, I want to report here, only 71 out of 95 had duration response greater than 6 months. Well, we got to recognize that there's only 71 because many of these patients dropped out of the study, right? Several of these patients died. Several of them went for resection. Several of them withdrew consent. So, this data is not censored, but all of these patients dropped out. That is why we're having a 71 out of 95, right? These are 24 patients have come up otherwise. Otherwise, we'll have a much, much higher percent of patients duration response greater than months, close to 100% out here, right? Because there was no local progression that was seen. And the median range of the duration response that was reported is 295. Remember, we start imaging at 2 months and we go to 12 months. So really, it's a 10-month window. So the maximum you could kind of have is about 300 days anyway. So we're kind of hitting the duration response that's kind of maximally possible. In terms of activity that was delivered, what I'm showing you here is just a splash of the tumor doses, and that was achieved here. So you can see here in x-axis is the tumor observed dose. This is verified post-treatment based tumor doses. So this is not planned. So you can see we can achieve very, very high doses. And what is shown in gray are some of those 9 partial responders that we see out here, right? So you can see they're kind of intermixed here. You really don't see a dose threshold or anything like that in the data. What I want to kind of show you here is what we planned and what we delivered were very concordant, right? So you look at activity, they match pretty well. If you look at the volumes that were treated, right? Very good concordance there. If you look at the untreated liver, what was spared, again, what was planned and verified, very good concordance there. If you look at the mean dose that was delivered to the tumor, we planned 150 to 400. In reality, what we saw was 513 gray was the median tumor dose with a range of 96 to almost 2600 gray, right? So that's what we got here. And the reason we can get higher doses to tumor greater than 400 is if you do rat seg, right? And the tumor has much higher uptake, you're going to have higher tumor dose than 400 gray. 20 patients actually underwent curative treatments, right? This is very exciting to see. So we had one patient that went resection pretty early on, about 3.5 months after SERT. But then we had 19 patients that actually were eligible to go to liver transplant and have really, excellent curative treatments out here. And the median time from SERT to liver transplant was 10 months. Okay, it's a very important finding. In terms of adverse events, what you notice that most adverse events are mild or moderate. Okay, I mean, when I say most, about 85% is grade 1 and 2. There were really only 4 serious adverse events that we saw in 3 patients that were device or procedure related, right? There were 2 cases of abdominal pain, 1 case of radiation hepatitis, and 1 case of nausea. All of these were mitigated by medication, okay? But these are the 3 adverse events. Over 95% of the patients showed stable liver function after treatment, right? So this is the first line treatment. We did, liver-directed therapy, and it's very nice to see that all the labs showed stable function, okay? There were 17 deaths since 2021, since we approved the patients. 3 of them were due to disease progression, but none of them were deemed to be related either due to the device or the procedure or anything like that, okay? And this is natural progression of history. So what I would like to end with is some summary and key takeaways here is that the best objective response for 9 months was 99%, which I think is outstanding. And that was deemed by independent central review with a complete response rate of 90%. The duration of response was close to 300 days. And like I said, upwards to 95% had duration response greater than 6 months, though we can report only 75 here if you don't censor the data. The median target size was 2.8 centimeters. The median tumor dose was 513. And most adverse events are mild and very manageable here. And more than 95% of patients had stable liver function. So DORE was really the first pivotal prospective multi-center study of Y90 ribalization using partition dosimetry for the treatment of unresectable HCC in the US. This led to the FDA approval of using resonant microspheres as a first-line treatment and its expanded indication. Partition dosimetry is now in the eye of view for HCC, at least in the US. In the past, it was not there. We didn't have partition, so now we can do that. And very exciting that cert dosing schemas with 3-day pre-cal, right, due to the study has been fully vetted and developed. So, we can really take these information and translate to other centers. And I want to kind of end by kind of showing you the splash of all the investigators that participate in the study, and sincere thanks to the patients, the families, and CERTEX and the investigators who basically supported the study here. So with this, I would like to thank you for your attention. Thank you.
Thank you very, very much. Super impressive data. Thanks a lot for sharing, really. Now, before we jump to the discussion and the questions, I will give the floor to Professor Kim, who will now be sharing his experience in South Korea. Thank you very much.
Thank you for inviting me. My name is Hyo-chul Kim from Seoul, Korea. Good morning, good afternoon, good evening. I'm a big fan of radioembolization, so my email address is radioembolization. This is the number of Y90 in Korea. Last year, more than 1,000 cases, 1,030 patients received Y90 in 40 hospitals. 30 hospitals have the patient number over 100. From December 2020, Y90 has been partially covered by the National Health Insurance. So patients' out-of-pocket money was cut in half. So during the last 5 years, the number of Y90 has markedly increased. So before 2020, Y90 is a kind of a Hermes bag, but from 2021, Y90 is a Chanel. Blue line is the number of Y90 in our hospital. So last year we performed 271 cases, and I treat 226 HCC patients with Y90. The blue line is the annual number of tests in our hospital. So about 10 years ago, we performed 30,000 cases of tests every year, but last year we performed 1,500 cases of tests. We do conventional tests, repeated tests in 99%. We seldom do TAP tests. And nowadays, systemic therapy is popular in advanced disease and early conversion to systemic therapy in patients with taste refractory tumors. And Y90 has popularity for large HCC. So nowadays we do taste in small tumors, small treatment naive tumor when ablation is not applicable, or small recurrent tumors after other treatment. The red means number of ablations. So during the last 5 years, the number of ablation is decreasing. This is the proportion of TACE and radioembolization in treatment naive patients. So in the past, we commonly do conventional TACE. In early 2010s, we do depth TACE in medium-sized tumor or large-sized tumor. But in 2020s, large tumors are commonly treated with Y90. Small tumors are commonly treated with CTACE. And depth TACE is commonly used for TACE with high long shunt fraction. In Korea, systemic therapy, if systemic therapy is initiated, the following TACE or local therapy is not reimbursed. So in patients with a high long shunt fraction, we perform TACE for shunt reduction. So depth TACE has less post-embolization syndrome than conventional TACE. So we performed a TACE for patients with high long shunt fraction to reduce long shunt fraction. This is the proportion of TACE versus Y90 in large single HCC over 6 cm. So in the past, we performed the TACE, but nowadays, in mostly we do Y90. And some patients, about 10 or 20% of patients receive the TACE because they have a high long shunt fraction. This is the trial class before 2020 and 2021 and 3, and this is the last 2 years. And most patients have a trial class A5, more than 85%. In most HCC patients in Korea, they have good liver function, trial class A. About 10% have a trial class A6. Less than 30% have a trial class B. So I hate Y90 for trial class B. This is a BCLC ABC stage. Before 2020, BCLC ABC has a similar proportion, but during the last 2 years, more than half of patients have a BCLC A because during small or medium-sized single tumor received Y90 during the last 2 years. This is tumor size before 2020 and the last 2 years. Blue means tumor smaller than 3 cm. Red means tumor between 3 and 5 cm. So in the past, most patients have a tumor bigger than 5 cm, but nowadays, half of the tumors are smaller than 5 cm. So hepatologists and hepatic surgeons begin to think about Y90 in small or medium-sized HCC. So CTACE has a severe post-embolization syndrome, and Y90 has minimal post-embolization syndrome. And in America, probably most of Y90 are performed on the outpatient basis. However, in Korea, we do Y90 inpatient basis. So 92% of patients are discharged the next day. Only 2.6% of patients were discharged 30 days or later after Y90. So Y90 improved the quality of life of attending physicians. So attending physicians request Y90 again and again in our hospital. So this is a common treatment option for unresectable HCC. Small single tumor commonly treated with ablation or CTACE, but nowadays Y90 has getting popularity slowly. If medium-sized or large-sized single tumors are commonly treated with Y90 in our hospital, multiple small tumors are treated with a CTACE, or large multiple tumors, and large tumors are treated with Y90. So the Y90 is a kind of a debulking tool, and then small residual tumors are treated with a CTACE. And unilobar tumor with PVT can be treated with Y90 followed by systemic therapy. But nowadays, our hepatologists prefer upfront systemic therapy in patients with PVT. Bilobar disease or metastasis, I don't do Y90 in these patients. So in BCLCA, most of patients in doorway study, they have small tumors. So in BCLCA, if tumor is smaller than 3 cm, I think in terms of local control, ablation has the Y90 has a similar outcome with ablation. And I think overall, so in terms of overall survival, ablation, Y90, and CTAs may have a similar outcome, but the pain or serious adverse events is much infrequent in Y90, I think. Some patients, even in small portion of patients, have a serious adverse event such as bleeding or bowel perforation after ablation. So in terms of pain or serious adverse event, I think Y90 is winner than ablation. But the cost is a problem. In Asia, Y90 is not reimbursed. In Korea, the half of out-of-pocket money is covered by the government, but all other Asian countries, patients have to pay the 100% of the Y90 cost. But if a tumor bigger than 3 cm, I think Y90 has better local control than CTAs and much less pain and adverse event compared with the CTAs. So I think if patients have money, Y90 would be a dominant option regardless of tumor size. In Asia, the large tumors are commonly treated with Y90. Small tumors still are treated with ablation or CTAs. So I want to say how I calculate the radiation activity in large HCC. Basically, I like super selective treatment in large HCC. I try to save normal liver as much as possible. I try to maintain the liver function in patients with a large HCC because the large tumors have frequent recurrence. So subsequent treatment will be given to the patient. So maintaining liver function is a very important issue. And in Korea, the deceased donor liver transplantation is not an option for HCC patients because of there are so many liver cirrhosis patients. So DDLT is not an option for HCC patients. If patients want to receive liver transplantation, they have to receive the living donor liver transplantation. So 10% or 20% of patients can have a living donor liver transplantation. So in most patients, liver transplantation is not an option. So for the subsequent treatment, I try to maintain the liver function in large HCC patients. So the easiest way to maintain liver function is the super selective treatment. In this paper, the median tumor size is about 8 cm, much bigger than doorway study. So mean observed dose is calculated by single compartment dosimetry. It is very easy. Tumor observed dose can be calculated with partition dosimetry, multi-compartment dosimetry. So this is a simplistic program image, and in partition dosimetry, tumor shows hot radiation activity, and the Y90 microspheres are deposited preferentially into the tumor. And virtual tumor observed dose can be calculated with assumption that the assumption is all microspheres are deposited in the tumor. So virtual tumor observed dose can be calculated with a single compartment dosimetry, and we can calculate before the Y90 treatment. So the mean tumor size about 8 cm, and mean observed dose is not useful for differentiate complete response from the partial response. Pre-treatment tumor observed dose, which means partition tumor observed dose with SPECT CT, or you can see some the tumor observed dose may be useful to differentiate from CR from and PR. However, there is some overlapping of tumor dose between CR and PR. This is post-treatment tumor observed dose calculated on the PET CT. In Korea, we performed a PET CT in all patients the next day of Y90. So if tumor observed dose is under 300, complete response is very rare. If a tumor observed dose over 300, you can we can have a complete response. So my target tumor observed dose is at least 300. This is a virtual tumor observed dose. If a virtual tumor observed dose is under 600, complete response is very rare. So my target virtual tumor observed dose is at least 600 in the curative setting. So the tumor observed dose can be calculated by partition dosimetry, but we have to know the tumor volume, treated liver volume, and TN ratio. But treated liver volume may not be accurate. TN ratio may not be accurate. Mean observed dose, to calculate the mean observed dose, the only one we have to know is treated liver volume. To calculate virtual tumor observed dose, the one thing we have to know is only tumor volume. And virtual tumor observed dose can be calculated with only tumor volume, and its calculation is so simple. And if we do super selective treatment in hypervascular HCC, virtual tumor observed dose is very close to tumor observed dose. So in the curative setting, my target tumor observed dose between 300 and 600 by partition dosimetry. My target virtual tumor observed dose between 500 and 1000. And we can calculate the virtual tumor observed dose before the treatment. So calculation is very easy. And tumor observed dose on SPECT CT can also be calculated prior to Y90. However, the injection site of MAA and Y90 may be different. And there is a misregistration issue between CT and SPECT image. And SPECT image has inherent low resolution blood image and respiration artifact. Respiration, the misregistration, and the perfused volume may not be inaccurate. And tumor observed dose on PET-CT cannot be calculated prior to Y90. So this is my target tumor observed dose in large HCC with curative setting. I consider the liver function, age, the tumor shape and tumor location, and some biliary stent, or considering the future liver remnant, it means the untreated liver volume. So I adjust my target tumor observed dose between 300 and 600 with the curative setting. If in palliative setting, my target tumor observed dose just 100 or 200. And my target virtual tumor observed dose, I also consider the tumor vascularity and the degree of the super selection. And then I adjust my target virtual tumor observed dose between 5 and 1000 in curative setting. And this is true personalized dosimetry. Thank you for your attention.
Well, thank you very, very much. As you said, it's a very personalized dosimetry. That's very excellent. Thank you both for your presentations. Now we have time for discussion. And so we received a lot of questions from the audience. But before we start, just add a comment, because listening to you guys, I mean, it shows how much radioembolization is constantly changing. And that's one of the reasons why it's so hard to analyze, because it's a treatment that is offered to a very wide spectrum of patients, from very limited stages to advanced stage with vascular invasion. So we have different challenges depending on the type of patient we treat, and each indication is pushing against its own competitor, like ablation or surgery on the one end, or systemic therapy on the other end. So that's my comment number one. And comment number two, and it goes with what Prof. Kapeda showed about the doorway, is that up until now, there has been a narrative about the dose that we should reach depending on the platform or the type of beads that we use. So we have recommendations and guidelines and publications suggesting that raising spheres might need less dose to be effective, and that we need more with glass spheres. And what you showed is that I think it's a wrong way of approaching the problem. It's not a matter of type of beads. It's a matter of type of patient and stage of tumor. And the dose that you showed, the dose that you reach, and it goes with what Professor Kim showed as well, shows that even with resin spheres, we should go very high. We should target at very high dose. So it's really not a matter of thresholds based on the platform. It's a threshold based on the patient and the tumor burden, as Prof. Kim showed in this last slide. Is very, very important to me. Now, I will try to share some of the questions that we received. And the first ones are for you, Prof. Kapeda. It's about precisely dosimetry in the doorway study. So one of the questions was about how was it handled in the doorway study? How was the dosimetry handled, especially because some of the customers or our physicians are more interested in non-segmentectomy approach. So what was the approach in this study? Because we have very specific and relatively small tumors.
So I think, when we did doorway, one of the first things you got to look at is you got to look at what is the disease-free patient liver volume. Okay, that's a very important consideration, because safety is something we start with first. So first thing we do is we segment all the tumors. We look at the patient's height and weight, and what we have come to recognize, at least in our practice, and we're kind of growing that, is the liver has a metabolic load size, what I mean? And we have to keep that into consideration. And we have looked at data from surgical literature, and it shows that, if based on this metabolic load, you can resect, substantial fraction of the liver without causing any harm. And we've used that model. So for example, what you're saying is, if you have more than 40% of your liver based on metabolic load to be disease-free and that you're not treating, then you can really, you don't have any dose limits on the rest of the 60% of the liver. So we've leveraged that. Once you go below that, then you have to cap the dose limits. And once we went below, I think about 30 or 33%, we were not eligible for treatment because we don't have enough margin. So going to what Professor Kim was saying, patient selection is very important, right? You got to choose the right patients, because otherwise you can harm them. So that's what you do. Second is, when we look to see, are they RAD-seg patients or partitioned patients, right? So we segment all the tumors and we segment the perfused volume. And it's very important that when you do the scans, you get SPECT CTs or even contrast CTs, or the cone beam CT or fan beam CTs of each of the catheter locations, so we can segment the volume of those territories, right? So we know exactly when. And in this case, we also mark the location of the catheter. We don't want to wiggle the catheter and misdirect it, okay? So then once we see that, if it is one or two segments, then we were able to RAD-seg because we had enough liver spare that we could manage that. If it was partition, we actually looked at the MA scan, and the physicians, the attending physician, drew the tumor, the perfused volume. We did a prospective T2N calculation, and based on that, we would ask the provider what sort of tumor dose levels do they want to achieve. They had a range of 150 to 400. Some would use 300, some would, depending on their practice. And that is how we actually did the planning dosimetry for them. We just go back to post-treatment dosimetry. After all these patients were treated, depending on the site, they either did post-treatment SPECT CT or post-treatment PET CT, okay? Those images were sent to us after treatment, and we were able to take those same ROIs that were drawn and figure out what was the uptake on the PET CT and SPECT CT, and we were able to do partition dosimetry using PET CT and SPECT CT post-treatment assessment. That's how we calculated the doses of these patients. So I'm not, hopefully that answered, and we can add clarification.
No, very much so. Because it's very logical. If radio-EMBO is offered to a very broad spectrum of patients, on the one end you will have the patient in the doorway study with small tumors, so you aim at RAD-seg, and you compete against ablation or resection in those patients that cannot undergo resection or ablation.
Right.
And then you have to think like someone who would resect or ablate. The key point is the amount of liver that will be functioning and not be radiated. If you have enough, the sky is the limit for the dose. You just know you should not go below a certain threshold, but then we have to give a high dose. Now, whether or not we need to give a high dose or a huge dose, we don't know, but I go with you. And it's true that it's a different approach if you have more advanced stage or vascular invasion. In that case, you cannot think like that. So yeah, I will go very much with you. So if you are in a RAD-seg perspective, think about the liver function and the liver remnant, and then you hit hard. Do you know in the doorway study what was the rate of complete pathological response in the few patients who eventually underwent second?
It's a very good question, and it is something, you know, we actually didn't write that as part of the study to look at basically histology and resection samples to score the histological samples. We didn't write that in the study, so we actually don't have that data prospectively collected. How many of those patients had CPN? It is something we're looking at. We'll have to write an amendment and retrospectively collect that data because, you know, this is a prospective study, right? So everything has to be done upfront. So that's it is the strength and yet some of the limitations of the study. You know, we cannot go back and change things willy-nilly because all of this is defined upfront. So we have a plan to go back and look at that and see which ones have had CPN.
Yeah.
But I think at the same time, what's important to note is these patients got transplant. That is actually more important than whether they had CPN or not, right? That is the proof of the pudding, not whether they had CPN. That's what I would say.
No, you're right. You're right. The idea is that patients that are not initially inside a curative intent pathway can be brought back to this pathway thanks to radio-EMBO. And initially it was out of the question, and then because there's an extremely good response and durable response, we bring them back. Now, to which extent the amount of patients we can bring back, we don't know yet, but that's a very important point. Oh, and the second point would be that if RAD-seg is very effective, there might be also a subset of patients that do not need any secondary treatment because they're cured. Right. So that's why maybe complete path response might not be super important from a prognostic point of view, but it will be interesting for us to understand what we do and to better identify these patients that we actually cure and do not need any second line resection.
Agreed. I think science, we would learn a lot of science by seeing that, and I agree with that. You know what I mean?
Yeah.
But that's why we are exploring going back, but yeah. Correct.
Yeah. So just quick question before I ask one question to Prof. Kim, just because of course these are small tumors, so one might challenge the concept of non-ablatable, non-resectable. This was decided by local MDTs or it was central decision?
Local MDT decided that. So it may have been location, other core factors that went in there, but it was due to the site said, oh, we cannot ablate or resect. That's why we got it here. Otherwise, those would be the appropriate, those are the treatments they should approach, right?
Yeah, very interesting. Now, I want to ask something about to Prof. Kim, because when listening to your lecture, we see how much radioembolization is changing the way we treat those patients. And we see that because treatment we did before, we did less, like TACE, and we see more and more patients treated with TARE, Y90. And I think you did a great job trying to identify the best candidates, like patients with large tumors, patients with vascular invasion, and so on. And I really enjoyed your approach for dosimetry. Now, it means that you have a very strong collaboration between nuclear medicine and radiology, because it means a lot of discussion, communication. So congratulations. I just wanted to ask about the patients with portal vein tumor thrombosis. You said that in Korea, most of these patients will have first-line systemic therapy. It's correct?
Yes, I think more than 70% of PVT patients are treated upfront systemic therapy, probably.
Yeah. So you know what? It's very interesting because we have the same experience in France and in Europe, and maybe probably in the US you do it the same. But it's interesting because we all see the number of cases treated by radioembo explode. The curve you showed, we have that for all the countries. We know in the US it's been now the first treatment for bridging or downstaging before transplantation since 2023. And yet, if we look at the recent update of the guidelines from Northern America, from Europe, from Asia, radioembolization still is an option, something possibly as a second line, third line. So there is some kind of discrepancy between what we do every day and what is still currently recommended by medical oncology. But if you look at the results of systemic therapy in patients with PVTT, it's not that great. Because, for instance, the subgroup analysis of the IMBREV trial or the Himalaya trial, anytime you have a vascular invasion, the results of immunotherapy are really not that great. But then if you look at registries or studies about radioembo for patients with VP1, VP2, the results are significantly better. So I hope in the next years, we will manage to change the guidelines to show that first-line treatment should probably be radioembo. Okay, you can add immunotherapy if you want. So do you have the same feeling, or is it something that is different in your institutions?
I agree with you, strongly agree with you, and I insist Y90 must be primary option in portal vein thrombosis. But in patients with unilobar disease, we can do ablative Y90, and outcome is very good. In bilobar disease, the tumor dose must be lowered. It is just palliative Y90, and then followed by systemic therapy. That is must be standard treatment. And some patients with PVT have AP shunt. So in AP shunt, if contra-lobar AP shunt, I think Y90 is contraindicated. And if the lobar AP shunt and patients have good liver function, chapter class A, in patients with IPSI lobar AP shunt, I can do Y90. And so I insist Y90 must be performed first in patients with PVT. So I discuss with my hepatologist. However, hepatologists have several clinical trials with several drugs. So most PVT patients are enrolled in the clinical trials with systemic therapy. That is problem.
No, you're right. You're right. You're right to clarify that I was talking about the patient with unilobar PVT and not bilobar disease. In that case, for systemic therapy is of course the first line treatment. And you're right about the trials. Although more and more trials about systemic therapy consider advanced PVT as an exclusion criteria, like VP3, VP4. Now they exclude those patients from the trials. So that might be an opportunity for us. Prof. Capella, you want to comment?
I think one of the takeaway lessons we should learn here is the guidelines look at prospective data. Okay, they weigh that kind of level 1 evidence far stronger than retrospective studies. So perhaps one point I would like to make is the Y90 field has, if you look at the proportion, we have a lot of retrospective studies and lesser number of prospective studies. So one way to really influence guideline, I would make a call to all the participants, is to engage in prospective studies, right?
Yes.
Prospective studies of PVT doesn't have to be multi-center large, but prospective studies are weighed in a lot heavily by the guidelines, because we're competing in medical oncology, right? So you go to the tumor board, we got a study, well, they're going to accrue that patient study. So the onus is on us to develop these studies and offer these alternatives. I want to thank you.
This is a great point. We have to challenge them with their own weapons. So they believe in prospective studies, not necessarily randomized studies, but prospective studies.
Yeah, prospective.
Like very well curated registries, like for instance, the proactive registry that has been published recently, 1,000 patients, real life with radioembo. These are very good data. And the doorway is a precise, excellent example of that. Different type of patients, but still an excellent, very strong data that you cannot really challenge because these are real prospective studies. Now, I do have a few more questions in the chat, and I would say most of them are about the dosimetry or around dosimetry calculation. One is about the shunt that was mentioned by Prof. Kim. And because it's true that initially, a long time ago, MAA was all about the shunt. Then it transitioned to personalized dosimetry. But how do you guys compute this shunt? Do you do like 3D, 2D models? How is it in your institution?
Okay. So we've actually looked at lung shunt quite a bit here. What we tend to do is we do planar. So in our practice, we do planar and we do SPECT CT that includes part of the lung and part of the liver. So in our routine practice, we do planar. If most of these patients have low lung shunt fractions and don't really impact your dosimetry calculations, so we stick with planar. If planar is above, let's say 15% or 10, 15, 20%, then we come back to the SPECT CT and look at those calculations. That is what we do in our routine practice. Okay. Now in doorway, it was all done with planar. However, I will tell you one thing. We've written papers on these things. When you take planar, for many years, people just use the geomean images to do lung shunt calculation. In my opinion, and we have papers on that, that is incorrect approach to do that. Okay. A proper approach to do it is to use a single view imaging, either an anterior view or a posterior view. The liver is primarily anterior organ. So in our calculations, we actually do all 3 LSFs, and we're able to show that if you use the anterior view, most of the time we get the lower lung shunt fraction. So we are able to, based on published literature, looked at planar, and we look at the 3 different views and decide should we use anterior view, depending on the segments, anterior or posterior, and use that kind of views. That's how we manage the lung shunt in here. The couple of other things we do is we look to see on the site to see what is the kind of the count density in the right versus left lung, because we know there's a lot of shine through that is coming from the right lobe into the right lung. So we also, if there is a lot of discrepancy in the lung uptake due to shine through, we comment on that so the sites can properly draw the contouring. So the LSF actually is a little bit, you have to not only acquire the data, but you have to also contour the data correctly, right? So there is a lot of nuances in here. But that's how we did it. So based on planar, no 3D into it.
Great, very clear. I have maybe a final question for you both. And this is, I think, one of the strong points about Y90 is the quality of life and the toxicity profile versus other treatments. So in the doorway, it's very clear, very few serious adverse events, and it's also what Professor Kim said about the tolerance. So you said, Prof. Kim, that in South Korea, most of the patients will still be treated they will stay like 1 night in your institution. In our institution, it's outpatient clinic most of the time they will go out. I don't know, how is it in Texas? Is it the same for you?
Yes, it is outpatient. So we don't have all outpatients. Yeah.
And but do you think that, Professor Kim, do you think the reason why they're just kept one night is for financial reason or for medical reason? Because it's most of the time it's so well tolerated that the patient can go out and is very happy with that. That's also one of the reasons why they not enjoy, but they favor this experience, because it's really, they go in and out, and toxicity is very, very mild.
Yes, so in Korea, the main problem is day ward, or the day ward is not so popular in our hospital and in Korea. So we cannot do outpatient clinic. And within our angiography suite, there is no room for the patients for resting 3 hours. And our nurses, number of our nurses are very few, so they cannot take care of the patients. So if we have a large recovery room and we have more nurses, we can do outpatient Y90, but we don't have any facilities, so all patients are admitted. It's not medical issue.
Well, which is also a very important point, because radioembolization is all about logistics, coordination between departments, between nuclear medicine and radiology, coordination with the oncology department, and also coordination with the nurses and everything. And so it's challenging, but I think it's also very possible. So I hope that in the near future, you will be able to overcome that and offer this outpatient clinic experience. Now, it's 3 p.m. Paris time. And it's been 1 hour already, so time flies very, very fast when it's fascinating and you have passionate faculty like you guys. I think it's time to unfortunately close this webinar. Now, as you heard, it's going to be recorded so you can review it afterwards. Feel free to reach us as well, or Surtex, if you have any additional question. We try to address most of them, but this must not end with the end of the session. Keep asking questions and make it a very vivid community. And Antoine, I will give you maybe the final words of the webinar. Thank you.
No, thank you. Thank you to the faculty. I had a great time listening to you, and thank you for all the participants. I know it's a time that you have committed to that, so I appreciate that. And yes, we will pass all the questions, and we'll make sure that you have the on-demand webinar as well if you want to send that to some of your colleagues. So thank you very much.
Thank you again. Everybody have a great day. Bye-bye.
Bye-bye.
Thank you. Bye-bye.